Before we begin the discussion of thyroid pathology, let's first take a look at normal functioning and a review quickly of thyroid hormone synthesis. Let's begin. HPT Overview. Hypothalamus, Pituitary, Thyroid Axis. The classic prototype physiologically of your negative feedback mechanism. Up until now, we've looked at one major positive feedback mechanism, and that was in fact oxytocin. Here, with hypothalamus, we're releasing TRH. Please do not forget that TRH is also responsible for releasing prolactin from the antipituitary. And we then land upon the antipituitary, release TSH. TSH will then bind to a very important receptor on your thyroid gland, known as your TSH receptor. That becomes important to you pathologically in Graves' disease, where a type 2 hypersensitivity type of thyroid-stimulating immunoglobulin is then going to bind to that TSH receptor. We'll talk further when we get into details about thyroid hormone synthesis of a very important symport called your sodium iodide symport. From your thyroid, you're then going to release T4 in great quantity, 20 to 1, 15 to 1, depends as to whom you speak to, but point being is T4 is released in much greater concentration or ratio than T3. And then all of the different organs that your thyroid hormones then works upon. It could be the liver, it could be the intestine, it could be the heart. It could be just about everything and anything, including your bones. In this picture, you have two columns. On the left, you have a stimulatory, and on the right, inhibitory. And as and when I can, I'll go ahead and start putting in clinical applications. Let's begin with stimulation with alpha-adrenergic agonists. The opposite of this would be alpha-adrenergic blockers. Inhibitory. Also keep in mind that you could have nodules within this thyroid gland, and when you do, remember that sometimes it could be a space-occupying lesion and therefore decrease the release of your thyroid hormones, or really, anywhere up and down your axis, you could have a tumor that's inhibiting the release, a space-occupying lesion. Stimulatory, TRH, estrogen. Inhibitory, somatostatin. Dopamine, for the most part, think of it as being or exhibiting inhibitory type of action on your thyroid gland. Dopamine, however, in terms of inhibitory action, would be with prolactin and perhaps shares a little bit of inhibition with growth hormone. Glucocorticoids, chronic illnesses. Chronic illnesses is very important for us. How do you feel when you're ill? Not too energetic. Maybe if there were symptoms that you wanted to equate it to, it would be more so along the lines of hypothyroidism. We'll talk a little bit more about chronic illness. Stimulatory. TSH receptor stimulating antibodies is the full phrase there, ABY standing for antibodies. Whereas inhibitory, TSH receptor blocking antibodies. And so here, if you're thinking about, once again, some type of autoimmune disease such as Hashimoto, and then keep in mind that at any point during thyroid hormone synthesis and release, you could have destruction of thyroid hormone synthesis. We'll talk more later. Iodine could be both inhibitory or stimulatory. Keep that in mind. The way that it could be stimulatory is that if you're required to synthesize thyroid hormone, then iodine obviously would be responsible for the key element of creating your thyroid hormone. Or if there was too much iodine, at some point in time, you might have a negative feedback. But in both instances, keep in mind that you may result in goiters, iodine deficiency or iodine excess. Lithium is a big one. Lithium. Two major organs that lithium is responsible for causing dysfunction, and that you're responsible for. Number one, thyroid gland, and number two, and down the kidneys, bringing about a nephrogenic type of diabetes insipidus picture. The thyroid gland itself and its histology. What you're seeing in the image is the middle area that is homogeneously eosinophilic and pinkish, then surrounded by a boundary of what's known as your follicular epithelial cells. Now, what we'll do further is, and what you've already done, is take the follicular epithelial cell and have your basolateral side facing the blood, B, basolateral, B, blood, and then the apical membrane, which is then facing the colloid, that homogeneously pink region that is then responsible for housing or storing your thyroid hormones. Thyroid hormones are made in the follicular epithelial cell, as we shall see, the key element there being iodine, regulated by TSH. Remember, every single thyroid tissue or cell has a TSH receptor. That TSH receptor will be incredibly important for us to stimulate or initiate thyroid hormone synthesis because it brings about sodium iodide symport, as we shall see. Serum T3 and T4 are then bound once they get into circulation. Remember, these are lipid soluble. Prior to this, they were water soluble. What do I mean? The TSH receptor on the thyroid gland, water soluble, a G protein type of signal transduction. But when your thyroid hormone gets into circulation, you know darn well that its effects within the nucleus and transcription, translation, and such is extremely, extremely critical and quite effective. So therefore, it'll pass through the membrane. So therefore, you need to make sure that you're able to regulate that. And so therefore, the liver then produces what's known as a binding globulin. Liver, not inside my thyroid gland right now. What I'll show you in a little bit is your thyroid globulin, and I've asked you a number of times, do not get the two confused, and you want to keep these separate clinically, as you shall see.